Thanks, Peter. So as mentioned, the topic of my PhD is an economic model of psychosis using actual treatment and health outcomes, which is pretty clearly put together to form the acronym MPOWER. I'm in my second year of the PhD in psychiatry at Oxford. And as Peter mentioned, my background is actually in economics and policy more than it is in psychiatry or mental health. So my supervisor is Professor Linda Lennox, who is an expert in psychiatry, and Apostolos Christos, who's an expert in health economics, and my research sits between those two things in terms of applying economic methods to improving mental health services. Let's go on. There we go. So as a bit of background, I'm sure a lot of you are aware, psychosis is a severe mental illness characterized by hallucinations, delusions, and other affective symptoms. The primary treatment for psychosis is antipsychotic medication, which is prescribed to stabilize symptoms during acute episode and to limit the risk of future acute episodes. To understand whether a medication for psychosis is cost effective, you compare the costs and effects of a treatment to the existing treatment, and if the effects, so on acute episodes, side effects, physical health, are worth the costs, including the cost of medication, the cost of service use, then you decide that it's cost effective. This has been a growing area of research over recent decades, especially regarding newer antipsychotics, maybe about 20 years ago. Usually focuses on the trade-off between effectiveness on acute episodes, things like extrapyramidal side effects, cardiometabolic side effects, and the class of medication. So similar research has been undertaken on psychological treatments, such as CBT for psychosis or family intervention, and psychosocial treatments such as case management or employment support, which are the other main forms of treatment for psychosis. In each case, the logic is the same. You define two mutually exclusive policies for each treatment, for example, CBT psychosis versus no CBT psychosis. Work out all the effects and costs on symptoms, recovery, service use, wages, and then decide if the effects are worth the costs. So the topic of my PhD is early intervention in psychosis, which is arguably the most significant change in psychosis treatment over recent decades. Not really a treatment, but a service model which packages together all the existing recommended treatments targeted specifically at early psychosis or first episode psychosis, and it's delivered by a standalone multidisciplinary team. The aim of EIP is to minimize the duration of untreated psychosis, which is associated with worse long-term outcomes, and improve access to evidence-based treatments such as antipsychotics, psychological therapies, etc. All the care is coordinated by a care coordinator who is only responsible for a small number of patients, usually recommended to be less than 15. Service users are provided 3 years of care from the point of first referral, after which they are discharged back to primary care or to community mental health care. So what treatment as usual was prior to the introduction of EIP. So the rationale for my study, EIP has been the national standard of care for early psychosis for almost 10 years on the basis that it is both effective and cost effective. One study cited in the official guidance for implementing EIP finds that for every £1 spent on EIP, the NHS saves £15 over a 10-year period, and that this is due to the effect of EIP on hospitalisation mainly, despite the increased cost of delivering care coordination and all the associated treatments. The complication is that the full package of EIP that's been evidenced in trials and implemented as a standard across the NHS isn't actually delivered very often. So only about 1 in 2 receive CBT for psychosis, which is the main recommended form of individual psychological therapy. About 1 in 5 receive family intervention. Case coordinator ratios, the number of service users per case coordinator, vary pretty dramatically from team to team, and over time, quite a lot of services or teams with really high rates of service users to case coordinators. The main constraint cited in studies of the implementation of the EIP is funding. Teams simply don't have enough money to provide all of the elements of care they're required to provide. The other constraint you can see in the audits of psychosis care in England are that many service users don't engage with the treatments when they're offered. So this raises some important questions. We're currently delivering an intervention that is different from the ones we have evidence for in trials. We don't know how much it costs. We don't know what the effects are likely to be. And more importantly, we don't necessarily know what we should do about it. So more money to EIP, we think, would improve the rate of receipt of EIP components and the outcomes of people receiving EIP. But how much is unclear. It's unclear which components we should prioritize first. Is this more important than the other priorities facing the health service? So we've put together two decision problems faced by EIP providers, i.e. the NHS in England, when faced with constrained budgets and partially delivered EIP. Which EIP components should providers allocate marginal additional funding to? So what is the most efficient internal prioritization of EIP components? And how much funding should the health service allocate to EIP? I.e., what do we get overall for each additional pound we spend improving EIP its current partial status? Our initial approach looked something like this. So it's more complex than the cost effectiveness research I've talked through so far, but it's the same fundamental principle. Instead of thinking of EIP as a single complete package of treatment that people can receive, we split it into a set of components based on the quality standards, literature review, and engagement with decision makers. So each individual could receive any combination of these treatments. For example, have case management, CBT for psychosis, and physical health checks, but not anything else. We would then estimate the relationship between each unique combination of components and some observable outcomes in the data, which would then value in the terms that are used by NICE, the National Institute of Health and Care Excellence, to evaluate cost effectiveness of cost and quality adjusted life years. So the first issue with that approach is that that's not really the decision we want to inform. Every EIP team more or less delivers all of these interventions to some people. Our model as planned would provide an optimal configurations, including or excluding components entirely, rather than marginally improving the rate of receipt of those components. Even if we built a model with treatment effects that were different for each combination for each individual, we wouldn't really expect or want clinicians to be deciding on individual psychosocial or psychological treatments based on a model of long-term costs. Instead, we've decided to focus on decisions at the service level around resources required to deliver each component and the overall budget required to fund those resources. For this, we need a different type of model. Instead of identifying every combination of resources and the resulting combinations of components and outcomes and so on, we just make some assumptions and draw some lines between the specific type of resources and their capacity to deliver specific components. For example, we're going to model how the number of psychologists determines the receipt and timing of CBT psychosis. This process is then repeated for the relationship between components and outcomes. So based on published literature, a component network meta-analysis, we can relate the receipt of a component within EIP to certain outcomes. For example, we know that family intervention might influence engagement, or employment support might influence employment. And those outcomes are then valued in the health economic terms that I mentioned earlier. We can incorporate interim steps like engagement as a determinant of whether or not people receive each component. Once we have a model that accurately describes this whole process, we can try out different decisions at the start, with different allocations of funding to resources, different levels of funding, and see how they play out through to the end of the process, different overall costs and effects for service users. So I've talked a little bit about modeling and the data, and I wanted to briefly describe what I mean by both of those in this study. The type of model we're going to use is something, well, we are using, is something called a discrete event simulation. So discrete event simulation simulates the times of events which occur in sequence, and unlike other models, time is discrete rather than in fixed steps. That's how it gets its name. So this is a very simple example of how a DES model might be used in the context of first episode psychosis. Someone enters the model with FEP. They are then placed on an EIP caseload. After a simulated amount of time, they are then discharged to a community mental health team. A certain amount of time after that, they exit the model by dying. And throughout all of this, we simulate their risk of experiencing acute episodes of psychosis. At each point along the chain, you accumulate costs, for example, the cost of providing EIP or managing an acute episode, and quality adjusted life years, so you experience lower quality of life during an acute episode. We can incorporate things like partial provision by having individuals see fixed resources at certain points in the model. If there aren't enough resources available, they enter a queue, and this leads to some people not receiving the components by the time they're finished with EIP or spending time on waiting. We can test policy scenarios by altering the structure or parameters of the model, pairing the two sets of simulated outcomes. For example, removing EIP from this model and sending everyone straight to CMHT would be the treatment as usual that most studies have compared EIP to. The actual model for this study is still a work in progress, but it's a lot more detailed than what we're here. So instead of a single box for EIP, we have 7 different pathways within EIP and a whole lot of pathways after it, and it simulates the receipt, all of those components and all of the different outcomes that can occur after you receive them. The biggest challenge in this approach is determining the structure. So what events can happen and when, and the parameters. So how long between each event, what are the costs, what is the impact on quality of life, and how do all of the above vary between individuals. Unfortunately, there isn't a data set that includes information on all the things we're interested in, so resources, components, outcomes, quality of life, and cost. That's a big part of the reason we need to use a model in the first place. But it makes it difficult to identify the structure of the model, estimate the appropriate parameters, and check if our model's doing a good job. What we do have is a data set from a study we've been working on for the NIHR on the duration of EIP care. So the National Clinical Audit of Psychosis is an annual case note audit of 10,000 people, a caseload of EIP teams, which checks their receipt of EIP interventions against NICE quality standards. We've linked that to all available physical and mental health service use data spanning 6 years. This gives us a great source of data on the relationship between overall resource use and component receipt, and between component receipt and short-term outcomes like hospitalization. So the structure for the PhD is to gradually build out the complexity of this DES model. At each point, we implement the model at a greater level of complexity or for a wider range of the disease pathway. We then test the new parts of the model against other external data, including the extended data set and other models, and a few other pieces of data here and there to confirm that it's doing what we expect and making sense as part of the process called validation. You can see we don't really get a proper answer to any of the main 2 decision problems until chapter 5, so the end where we can link it all the way and finally run the model under different policy scenarios and analyze the costs and effects. The full details of how the model will be developed, implemented, tested, and analyzed are available in a protocol document, which we'll hopefully have online soon, and the whole process of implementing it in terms of the code and the data will all be on a GitHub page that you should be able to look at. But to give you a picture of what we're in the middle of doing for the first chapter, we're looking to trace the relationship between resources and components received in EIP and ensure that the model is doing a good job of simulating that relationship. This is an interesting question kind of on its own. So as part of the NHS long-term plan, starting in 2019, there was an ongoing goal to expand timely access to NICE accordant EIP care with a commitment to increasing funding alongside to make that happen. So you can see 2 snapshots of EIP at a national level in England, so in 2019-20 and 2023-24, which is the last year we have all the available data for. You can see that the total spend on EIP has increased by 34% in nominal terms, so tens of millions of pounds extra spending on EIP, meaning still quite a substantial real increase despite the inflation over recent years. During that time, the number of people starting EIP has actually fallen very slightly, so access hasn't grown in the way that they've targeted. And the rate of timely access for people who have entered EIP hasn't really moved either, depending on how you measure it. From some other sources, it's actually fallen as well a little bit. So explaining how resources can determine the actual quality of services people receive is a really important one and a really live one. So as well as developing the model, we've been conducting the following analysis. So based on expert input, we've been adapting a staff calculator of what EIP would cost to deliver every component in full, which builds on work previously done as part of the guideline implementation. And that suggested that £8,250 per year per individual on caseload would be the target. And that's something that we're still well below despite those big increases in spending. Using costing methodology from the National Cost Collection, so a bit like what Nushin was saying earlier, but with real world data and with real linked mental health services data, we're going to estimate individual level costs of EIP in the extended data set and the relationship between costs and component receipt. And using a questionnaire from a small number of EIP teams in the south of England, we're going to look at the relationship between recorded staff resources and component receipt for 15 teams. We will then run the model to simulate each of these scenarios and compare the model results to our outside analysis. So I've got an enormous number of people to thank, especially because of how many people work on this other project that I've mentioned that have done all the hard work of getting these data sets together. That includes the PPI team on Extend, which is quite a big and diverse group of service users and carers, and especially the PPI leads on that, with the statistical people and qualitative researchers on that team, and then the people who provided the data and linked it and allowed us to access it in the ONS. So that's the NHS, the Royal College of Psychiatrists, Healthcare Quality Improvement Partnership, and all sorts of other people along the way. But yeah, thanks very much.